Hello, my name is John Jestus, and I'm a medical student at the University of Tennessee Health Science Center. Today, I will be presenting a case of disseminated histoplasmosis in an immunocompromised patient. This case is particularly unique due to the unusual source of infection, contaminated soil in a domestic snake terrarium. Disseminated histoplasmosis is a severe infection caused by Histoplasma capsulatum, a fungus endemic to regions in the United States like the Mississippi and Ohio River valleys. However, it is also prevalent in other parts of the world. While most people exposed to this fungus remain asymptomatic, those who are immunocompromised are at a significantly higher risk for severe disease, including widespread dissemination. Our patient, a 58-year-old female with a history of rheumatoid arthritis and Sjogren's disease, presented with 4 weeks of progressively worsening fatigue, chills, night sweats, abdominal pain, and diarrhea. Despite extensive history taking and testing, including imaging and lab work, the source of her symptoms was initially unclear. However, further investigation, including a positive histoplasma urinary antigen test and a bone marrow biopsy, confirmed disseminated histoplasmosis. This slide provides a comprehensive overview of her case, including her clinical presentation, diagnostic workup, and treatment. Let's take a closer look at the details of her case. On admission, the patient's vitals were concerning, with a fever, tachycardia, and hypotension. Initial lab results showed thrombocytopenia and elevated inflammatory markers. Imaging and enteroscopy findings suggested a widespread inflammatory process, but it was the positive fungal stains and urinary antigen that clinched the diagnosis of disseminated histoplasmosis. I have shown on the right side of the screen an example of a Giemsa stained specimen from the CDC that shows these fungal organisms in a liver tissue sample. This patient's immunosuppressive therapy, including adalimumab, methotrexate, and prednisone, made her particularly vulnerable to infections. Despite the absence of any recent exposure to infectious individuals or outdoor activities, her history revealed a significant detail. 4 months prior, she had cleaned out her partner's snake terrariums, which contained old, moldy soil. This was likely the source of her exposure to Histoplasma capsulatum. One of the most challenging aspects of this case was the diagnostic process. Disseminated histoplasmosis often presents with nonspecific symptoms, such as abdominal pain, weight loss, and fever, which can easily be mistaken for other gastrointestinal conditions. In this patient, gastrointestinal lesions mimicked more common conditions, delaying the diagnosis. Furthermore, the source of her infection was unusual. Histoplasmosis is typically associated with exposure to bird or bat droppings, but in this case, the contaminated snake terrarium was the culprit. This underscores the importance of considering non-traditional environmental exposures, especially in endemic areas, which are highlighted on the left side of the screen. Once the diagnosis was made, the patient was promptly started on IV liposomal amphotericin B, followed by oral itraconazole. She showed significant improvement and was eventually discharged on this maintenance dose of itraconazole. In conclusion, this case serves as a reminder that clinicians must maintain a high index of suspicion for fungal infections in endemic regions as presented here, particularly in immunocompromised patients. A thorough history and comprehensive diagnostic workup are critical for identifying and treating these potentially fatal infections. Thank you for your attention.